Welcome to this collaborative session on pediatric abusive head trauma. We will be discussing the purpose of this continuing education component for you and why it is now a requirement, the definition of pediatric abusive head trauma, the frequency or occurrence, particularly in Kentucky, symptoms and risk factors, as well as intervention and treatments and reporting issues for you. So if you'd want to follow along with your PowerPoint, we'll begin. In 2010, the Kentucky Legislative Session 314.073 identified that there needed to be a continuing education requirement for nurses in regards to pediatric abusive head trauma, or PAHT. In the past, or formerly, this was referred to as shaken baby syndrome. It is a type of domestic violence, and you have had some information related to this within your domestic violence continuing competencies within our program. The Kentucky legislator mandated that 1.5 hours of education is required related to PAHT. So within our program, we are providing that continuing education for you. It is referred to as the most common cause of child abuse that results in fatality and long-term disability. It may be from the result of blunt trauma to the head or violent shaking, and these are primarily the reasons for the head injury among infants and children. We will discuss what is the most common age group that we see this occurring in. Overall, child abuse and neglect continue to be a major problem within the United States. Our data, our statistics that we have from 2009 indicate that 1,770 children died from neglect and abuse. More than 40% of those deaths occurred in children younger than 1 year of age. So it's vital that you are aware of risk factors and can make appropriate assessments to help prevent this situation. This data came from the Child Welfare Information Gateway of 2011 and is the most current data that's available on this topic. The scope of the problem, we have to look at the numbers as well as cost and loss of function for infants and children, even as they emerge into adulthood and long-term complications. Non-fatal cases reported by state and local protective services in 2008 revealed a total rate of 58.7 cases per 1,000 children, and that's for children 3 years of age and younger. Of this total, infants younger than 1 year of age comprised 21.7 per 1,000 children in that same allotment and looking at that same spread of number of children. When we examine the medical cost associated with initial long-term care for victims of PAHT, that ranges from $300,000 to over $1 million. So it is a considerable loss of function, loss of life, and a need for awareness. So this is another reason why this has become a requirement in Kentucky. Kentucky has a high rate as well. So again, these statistics were from the CDC posted in 2010, and those are the most latest ones also. So what actually would be a definition for PAHT when there's a multitude of types of child abuse that can be seen? This is injury that occurs from vigorously shaking an infant or a child by the shoulder, by the arms or legs, or sustaining a deliberate direct blow to the head. Or it can be when the child is deliberately dropped. Out of these situations are these behaviors that are exhibited that inflict this type of injury. The type of injury that we see then is brain damage, blindness, paralysis, speech and language disorders, and even death. PAHT can occur in just a matter of seconds and from as few as 3 violent shakes. Generally, the child is under 2 years of age. So again, to point out the purpose of this presentation is that you would have the information to effectively and consistently assess for PAHT, that you could be an integral part of implementing interventions with families and children, be involved even within your community to help diminish or decrease the incidence of PAHT. It is hoped that now, after hearing this presentation, you can recognize predisposing factors that can be red flags to you to further assess a family situation. That you would be able to identify those individuals who are at risk for perpetrating PAHT, that you could further assess their risk factors and provide interventions. That you will have the skills to plan and implement preventive education within your scope of practice and within your organization that you are employed. That you will have a working knowledge base more clearly defined with PAHT, and that overall through your knowledge and your skills and your interventions, that you can assist with reducing this type of child abuse. It is hoped that you would be able to describe the significance of the problem, the occurrence, the frequency, and be aware of the changes in terminology that are now being used. To be able to identify the most common causes and reasons for PAHT and to readily identify them when interacting with individuals. And then again, that you can assess, treat, and help prevent within your scope of practice. When we look at the significance of the problem, the backdrop to why we even need this type of education is that the CDC has become the focal point of providing information and says that in 2011 they defined child maltreatment as any act or series of acts of commission or omission by a parent or other caregiver that results in harm. Now that encompasses all maltreatment situations. So when we look at just PAHT, we'll look at those as well. And then over time, child maltreatment can also cause an increased risk of leading causes of death in adults. A significant public health issue then is the basis for this initiative. Result in injuries that are considered related to PAHT. It needs to then further provide you information on how to intervene and assess the caregiver. The fatal child abuse that may result can be from repeated episodes, or it can be from a single impulsive incident. So there are a multitude of ways that this can present. The incidence, when we look at it now, it's 1,000 to 1,500 infants per year. Abuse is responsible for fatalities in 2,000 children per year. And of those numbers, interestingly enough, 60% are male victims. It is thought perhaps that in a dysfunctional relationship, the female may have such negative relationships and patterns of behavior directed toward the father of the baby, and if this is a male baby, reminds her of that gender and sex of the individual that she holds such a disdain for. 1/3 of the victims will die from their injuries. 1/3 of these will suffer life-changing injuries, and then 1/3 will have minor types of injuries. Causes and risk factors. One of the major issues that we see is that crying without being able to be calmed or quieted. So that would then be an important question to ask the mother or the caregiver. How often does the baby cry? What is the cry like? What calms the baby? What are you able to do to help the baby feel more in control of themselves and to feel more secure? So in understanding those answers, it may direct you to their lack of information and knowledge level about the crying that typically occurs with newborns. Their view may be that the baby should not be crying, and for a baby to cry for 30 minutes is not an abnormality, but their perception may be that it is. And so they're trying to stop that baby from crying. And in their situation of feeling out of control, they deal with this crying baby in, in a very harmful, injurious way. The parent or caregiver becomes frustrated easily and angry. They do not have a sense of control over their own emotions in the situation, and of course thinking of themselves and how the crying is affecting them rather than what does that crying mean in regards to the baby or what they could do to make the baby feel more comfortable. So it's a multitude of things that happen, but within that instant they lose control and they shake the baby. Sometimes what we see too as a risk factor is a premature baby or a baby with a disability. So we have a baby that's not that perfect Gerber baby. They do not have a baby that they perceive as being perfect, but one with a multitude of issues, and again their inability to cope with that crisis and that stress, and then topped with the baby crying and not stopping, then leads to this instant of loss of control. Now, I mentioned before, that there's an increased number of occurrences with males, and so again, that may be the mother's lack of knowledge or understanding of the baby's ability to stop crying, and that expectation, if it's a male, they're stronger and they should be crying less. And then secondly, the male infant reminds the single parent mother, again, of that bad relationship with the baby's father. Another thing that's a risk factor is when a mom gives up a baby for adoption and then changes her mind. So we already see that there's some decision-making, that impromptu, immediate, spontaneous changes without a lot of thought to the situation. And of course, the baby being small enough to be picked up and shaken or slammed is again a risk factor. So again, that's why we're looking at that younger age. And then of course they're totally dependent on that caregiver, and then the caregiver may be socially isolated. We see that as a common pattern. Being one of the multiple births, coupled with some other risk factors, again, may make that perfect storm when they have that added risk of social, economic, lack of ability to care for multiple babies. So these risk factors have been compiled by the CDC, and you're seeing that reference from 2010 for those. There is no single identified profile of the PAHT perpetrator. It is usually several things that seem to make this perfect storm, if you will. But we'll look at some of those that frequently appear on the list of things that you should now be aware of, and they should trigger you to ask another question or to assess for another area. Any young teen or early adulthood caregiver, a single parent, someone with lack of education. You know, I've already mentioned they may not have understanding of the normal growth and development. This might be an indication that you could look at if they have not completed high school, they don't have a high school diploma, then again that is just looking into that whole arena of lack of understanding of growth and development. Low social and economic status, they don't have that safety net of individuals in the family or support structure. It may be a dysfunctional family. They may be multiple people living in the household, and that changes from time to time. They have a high stress level, which typically is related to that socioeconomic status. There may be a large number of dependent children within the household, and this added baby at the end then just seems to be too much, you know, for this individual with these multitude of risk factors. We may even see within their history that they were abused as a child or neglected in some way, and this has become their pattern of parenting as to what they've experienced and how they have seen stress handled. Being in isolation, again, is another way to say that they don't have that safety net. They're alone for periods of time, particularly when you look at this young teen and low socioeconomic status and then being in isolation. These just seem to mount up as being issues. Then if we add into this area and think about substance abuse, again, that can be a strong indicator that there is lack of critical thinking and wise choices about their health and the environment for that baby. They have a history of mental health problems. Certainly that's saying that, you know, they have had incidents where, you know, they perhaps have not handled stress well, or they have a low self-esteem, and these can factor into an inability to care and understand for the needs of an infant. When there's a new adult partner in the home, you know, so that you should ask questions like, well, tell me about the home, who lives there, have there been any changes in the home, what are the roles of the individual that are in the home, so that you have a better understanding of that environment, because that certainly can be a risk situation in their profile. It may be non-biological or transient caregivers in the home. So out of her stress or need just to have anybody to care for the baby for a period of time, she may not make wise choices as to who that is. So it may be that individual, that transient caregiver, that's actually responsible for being the perpetrator. Feelings of inadequacy, you know, if the mother does not feel, you know, about who she is and what her needs are and how to handle her stress, she's not going to be able to handle the stress and needs of the baby in a very positive way. through all of these different profiles, you could see that this caregiver would often have exhaustion. So asking them questions about how do you rest, how much rest do you get, tell me how tired you feel, what is the normal day like for you. So are you seeing that she has any times that she's resting and that then can come back to the care of that baby, being rested and having a healthy ability to care for the baby. Limited anger management skills. There may be a history of, flying off about certain things, or when certain questions are asked, this certainly could be an indicator for you that there's an anger management. Any family that's unstable or dysfunctional, riddled within that situation can be the stress, the low socioeconomic status, and multiple other reasons. So looking at all of these together is a more complete way, but the unstable home. The parent who has rigid attitudes and who is very impulsive. Rigidness we see often with toilet training, being able to merge into the next developmental stage of feeding oneself, or toilet training, for example. Poor parent-child relationships, and then, of course, the real big one, they become so irritated when the child or infant is crying and feel that the child or infant should be able to stop that. They may have also seen that this baby was their chance at love, that somebody would love them. It was a possession for them, or to meet their needs of feeling and belonging. So often we see they have this negative view of themselves. So in your questioning, you would want to assess what is their perception of their self, their self-concept. Again, I mentioned an unwanted pregnancy, or making a decision to give the baby up for adoption and then changing one's mind can be a red flag of how will she deal with this baby at home when she's kind of waffled on did she want the baby or was going to keep the baby or not. Another one that we see is the unwanted gender of the child, and this often goes back to that male increased incidence of PAHT. Again, if this was an unwanted pregnancy and this is a male child, they may see the behavior or likeness or physical characteristics of this person they strongly hate. So this may be a reason for the PAHT. Then any baby with a chronic illness or disability, that is very taxing on the family itself, on the individual, the guilt, the socioeconomic factors that relate to that, the grieving for the perfect baby. So all of those instances need to be evaluated and to see if they are managing the situation and acceptance of that and have the support services that they need. A family that's in crisis related to a death, divorce, or a financial problem can be also a risk factor that then can lead to inability to deal with, a baby, particularly this crying baby. So triggers. The crying is a very large trigger, especially persistent crying that frustrates the caregiver, and they're trying to stop the crying, and so they then just shake the baby, which of course makes the baby cry more, but again, that's intertwined with their lack of critical thinking. They don't understand that the baby's cry is a way that the baby's trying to communicate a need to the caregiver. The shaking of the baby during this crying incident causes central apnea, it causes hypoxia, cerebral edema, and then ultimately increased intracranial pressure. Now, I've mentioned some times that are very poignant in regards to being a trigger, toilet training between the ages of 12 and 48 months. And again, that goes back to not being able to understand growth and development. Signs of pediatric abusive head trauma. It may not be obvious at first. There can be a range on the continuum of severity and specificity. In less severe cases, infants even may appear normal. So we look at other parameters of their behavior, poor feeding, poor sucking and swallowing, inability to move to the next developmental task, delays in motor development. Then also bruising on a child less than 1 year of age. Stories that are not consistent with the injury that's been sustained. Multiple bruising on multiple areas of the body, and bruising on the forearms where they've clutched or held the baby tightly as they're doing the shaking, so that we can see bruising in other areas. The increased intracranial pressure can cause the vomiting, and typically this is not vomiting like you would see with gastroenteritis, so it's without diarrhea or coming in contact with any viral infection, but rather the vomiting is related to the increased intracranial pressure. There can also be changes in behavior along with this added pressure around the cerebral area. So that could be lethargy, sleeplessness, and then progressive deterioration even into, lack of consciousness. Because of the pressure on the optic nerve, we may not see that they can track or move or focus their eyes as they should. They don't engage in that verbalization or smiling. That social smile should be there around 2 to 3 months and continue, and of course the verbalization should increase of 2 to 3 words at the end of 12 months, and we're just not seeing that, and more of a flat affect. The crying now may be high-pitched because of the increased intracranial pressure, and may have increased in the amount of time that the baby's crying. So these behavioral changes and even those of muscle tone and movements should be assessed for with your physical assessment and all well checks to make sure that there are no indications or signs of PAHT. So for every baby, you should be assessing to see and ruling out this particular situation. That is why the importance of this continuing education for you is to aid you in incorporating this battery of testing and assessments. A baby who has seizures or has rigidity and arching of their back, that opostontonous positioning, can also be an indicator of other conditions, but we need to look further and see are there any other signs of PAHT. Pupil sizes being unequal. They may even lose some vision, over a period of time. Inability to raise their head, to sit momentarily. There may be color changes. They may then start having some apnea and difficulty breathing. Of course, if their fontanelle is still open, remember it closes around 18 months, there would be a bulging fontanelle. Sometimes the causes, and when we look at the cerebral edema in PAHT, it's called a classical triad, that we have subdural hemorrhage, cerebral edema, and then retinal hemorrhages. So we can see that there can be from a direct injury, and then we can also have secondary events and systemic problems. Possible long-term consequences is see if we can prevent the occurrence. We give the parent the ability to deal with the situation more appropriately, give them the safety nets that they need, then we won't have these long-term consequences. But what that can include is profound disabilities that can affect the child's ability to breathe, swallow, and to do motor activity. Severe motor dysfunction, they may appear like cerebral palsy and various amounts of weak muscles or paralysis or even spasticity. Speech problems that would need lifelong help with those, mental retardation, seizures, and then all the way down to, ultimately to death for this individual. So it's important as a part of your history that you thoroughly, or that you're constantly thinking about PAHT, and know that, this is not caused by disease, it's not caused by immunizations, an incorrect method of implementing a CPR, SIDS, and it's not related to just a shortfall. All babies during infancy and early toddlerhood are going to have some falls. So it's not a fall of less than 4 feet, just when they're pulling up and then plop back down. It's not that type of fall. So you need to do a thorough history and make sure you have the timing of events. But when you're doing these assessments, you also need to remember your role is not that of detective or interrogator, but that you are completing a thorough medical and health history, and you need to document all your findings. Things that the parent says that may be questionable, you need to even put within quotes. Always use objective information. Mother states, and then what that is, or what you saw the interaction to be. You can't put a value on it. You cannot say, mother is inattentive. You must say what the mother did that demonstrated to you the conclusion that she was inattentive. So you have to be real careful on how you chart and document those types of things. So you want to do a thorough review of their history and notations of reports when they come back in, much like we ask you to do even in your simulation lab, to look to see if they missed appointments. Is there some reason they are not following through with their total care and comprehensive care for the pregnancy, the delivery? Are they missing appointments, for example? And then who cares for the child? Who gives her a break? Does the mother work out of the home? And where is the baby when this happens? Does she seek or have a delay in seeking medical attention? And for what reason? Is it a transportation issue like we saw in the simulation lab? But to be always aware, of these risk factors. Then, of course, there are a battery of diagnostic tests that can be conducted that help formulate, the diagnosis, head CTs, MRIs, skeletal surveys, skull radiology, and on down. You can look at those. But we're looking for any confirmation of injury to any area. When we're treating a child with pediatric abusive head trauma, of course, our primary concern is that of airway management, then, of course, cardiovascular management, and then dealing with the increase in the cranial pressure. If there's any bleeding, control of that, controlling seizures. There may be surgical treatments that may be required, fluid and electrolyte management. There may be nutritional alterations, additional consultations, special education classes for the parents, language development, and even physical therapy for the child, and being able to conduct daily living skills later, as the child grows. So again, you must realize that even though you're being very much aware of the risk factors and the triggers and you're asking questions, you are not in a role to blame or to investigate the crime. Your role is to initiate and provide optimal health and wealth for this child in the family unit. So you're looking at triggers, you're trying to prevent the incident, and then trying to clearly document as what the parent reports to you. It is a matter of reporting to legal authorities in regards to any suspicions that you might have, but you want to make sure that you've documented your cause for that particular position. So the nurses should know how to access Child Protective Services in whatever facility that you're working, whether it be emergency room, intensive care, that you know how to do that and how to initiate that report. You need to be aware of your local, state, and abuse hotlines. Chart objectively the signs and symptoms, the facts only, nothing but the facts. The caregiver behavior, what the caregiver says, and put that into quotes. When this record may go to court, maybe several years down the line, and you won't remember, exactly what was said or what you did. So you want to carefully to note that in your charting. Pictures should also be taken and included in the medical record. So ultimately, of course, we want to prevent it. We want to be on the other side of the situation. So, with a new pregnancy, if you're working in a prenatal clinic or within an OB unit, you should be assessing the family, the stability of the family, who's visiting, what's their role, what's the environment going to be like that the baby's being sent home in, what are the parenting skills, and what are their support systems. And I've already mentioned the change in mind and putting baby up for adoption. We probably need someone to be going into the home to make sure that that's progressing as it should be. Knowing the family economic status and connecting them with community resources that they might need that would help, such as WIC. How do they interact with the baby when you bring them in for the first time to see the baby? Are they turned off by the smell of the bowel movement, or they don't want to change the diaper, or they're repulsed at something that's going to be a normal sequence of events that they would need to be able to deal with? Do they understand crying is expected? Crying in the middle of the night, they may cry for up to 30 minutes. How to console a crying baby, what different cries mean, and what they could do about them. Are there newborn classes in your community that they could be referred to? Every opportunity you have, you want to assess the family, you want to teach the family, you want to demonstrate how you might care for the crying baby, for example, and then make all the referrals that might be needed for them. So we want to teach them not to ever shake a child or infant, to never discipline a child when they're angry, and do not hold their child or infant during an argument when they're having an argument with another member of the family. Make sure the child's basic needs are met. They know how much food they need, how to progress in their formula. If, for example, if they're breastfeeding, to be aware of what are the norms for that. How to offer a pacifier or a toy when the crying is occurring or they're upset. How to offer a diversion to get them quieted down. How to rock or walk with the baby and to hold him close when breathing, and be calm and more slow and deliberate about that. So we're providing anticipatory guidance. Every baby's going to cry. So how is this mom going to be able to deal with it? So make sure you make those referrals, education classes, and home visits if that's available in your community. Now, evidence-based practice, there's a mnemonic that she uses. It's called the period of purple crying, and this begins about 2 weeks of age and continues for about 3 to 4 months. And typical characteristics is it spells out, P is for the peak pattern, peaks around 2 months, that crying, then decreases. And then U is for unpredictable, crying for longer periods and starts and stops for no reason, that's normal. R for resistance to soothing. Baby may keep crying for long periods. P is for pain. Look on their face to see if there's a visual change that would indicate that There's pain in regards to an earache, for example. L would be long bouts of crying that can go on for hours. E is for evening crying, cries more in the afternoon and evening. So the word purple, this is based on a hospital education program that was used in California, and it has shown that it reduced cases by 50% to go over this particular information about purple and to be aware of what that means. Physicians, nurses, teachers, school personnel, social workers, coroners, so, you know, there's just about everyone is responsible for reporting. Matter of fact, if you are aware and you don't report, you can be liable for that too. So you need to remember to be aware of the significance of reporting. So PAHT is preventable. You need to, as a nurse, your role should encompass being aware of risk factors, to assess, to teach, and to provide care by being involved in the community and regarding families and helping to make that family unit stronger as much as possible. Remember the risk factors that are involved, and that these should become part of your assessments that you're including, and that you recognize the incidents and what age group, and if this event can occur in a matter of seconds and from as few as 3 violent shakes. So we need to know how quickly that this may happen. So I want to just review a few things with you again, just to make sure that you're aware of the significance of the issue. Kentucky has a high rate of pediatric abusive head trauma, and so therefore our state has moved towards looking at a prevention and reporting structure. The age that it more frequently occurs in is the newborn to 4 months, so under that 1 year of age. All the individuals who are responsible for reporting, factors that might be within a history that put them at risk, such as prematurity or having a particular disability. The caregiver who voices a great deal of frustration with the care of their infant or new baby, that the PAHT is typically related to, you know, at least 3 violent shakes. It doesn't occur from just bouncing the baby or rocking the baby, you know, or swinging the baby. The unwanted pregnancy should be a red flag to further assess and provide interventions. That you're teaching them methods to calm a baby who's crying. And remember the phrase purple. The Center for Shaken Baby Syndrome has introduced this, you know, as a teaching phrase to help them remember about not to act before they think, and remember that a healthy 4-month-old, for example, is going to have periods of time when they cry. So that's a normal situation that we would want the parent to be able to be aware of. Never to discipline a child when you're angry, and knowing some of the complications and long-term health care needs that can be the result of PAHT. So I hope this helps you add some dimension to your assessment, your history, and of course your interventions for prevention. So best of luck to you in your practice, and always keep this in mind. Thank you.